Teeth, which is part of our body, it's human tissue, okay? And you extract the tooth, you don't think twice, and you throw it away. And here they cleaned it very nicely and tried to sell it, by the way, to dental students. Yes. For decades, we know that teeth can be transplanted in the same patient, and also years ago, dentists were using a bank of teeth, and they were implanting teeth instead of implants. And those teeth usually were ankylosed, not like here, no PDL, but they were ankylosed, and they stayed there like ankylosed teeth until the root was remodeled into bone. But they were very well accepted by the socket. So this technique is very well known. Recently, in the last 20 years, because of implants, we forgot this idea of using human teeth as a good transplant. But we know still today, I hope so, that a valse teeth by trauma can be immediately put back into the socket, and sometimes we can get still periodontal ligament, but in most cases we have an ankylosis, a total ankylosis or a partial ankylosis. What is ankylosis essentially? Ankylosis you get because in the socket you have a lot of osteogenic progenitor cells, and they will attach to the root surface because they recognize the root surface is the best place to attach and then differentiate into bone. And this is what you get. You get apposition of bone directly on the root that you implanted back after the tooth was avulsed. And of course we have also resorption of the root after time. And again, like transplanted teeth, avulsed teeth also, sometimes they stay for 5 years, sometimes for 6 years, sometimes they stay for more. So what we learn from that first of all, that human teeth are very well accepted by progenitor cells, by osteogenic cells, and they are attaching and adhering to the surface of the roots. So this idea, yes, was also used today in Korea, but they have a tooth bank. What they do, they take, the doctor is extracting the tooth, sending to a special lab, they demineralize it, make a powder, a particulate out of it, and after 1 week, after they sterilize it, they send it back to the dentist. The disadvantage of this is that, of course, the socket is already started to be, the wound healing of the socket started already, the cells differentiated, and now sometimes this material can even disturb the further bone formation. So we thought about that we have to develop a way that immediately after extracting the tooth, when we have the fresh socket, to take the natural teeth and in a procedure that will take 15 minutes, we can replace it as particulate dentin, as a bone graft. And this is the best bone graft because it is autologous from the same patient, and we say again, from the same patient, and also we make it as much as we can clean and also bacteria-free. Why we need it? Because we know very well, every dentist knows that after extraction, we lose the alveolar bone. And this is a study, beautiful study, made by Horowitz from NYU, and published in 2012, and he summarized many studies, and he showed that during 3 to 6 months after extraction, we lose 3 to 6 millimeter width, and we lose also 2 to 3 millimeter height. And now what we get is what you see clinically, and I believe I don't have to convince you and don't have to do any studies, that you see it every day in your practice after extracting teeth. We lose the alveolar bone because the function of this bone is lost because we don't have the tooth. So we want to preserve it. So we know that in dentistry alveolar bone loss is a major problem, because if we don't have alveolar bone, we cannot even implants to put in. Following extraction of teeth, we get, as I showed you, in periodontitis and periodontal defects, we lose a lot of bone, and then the teeth are mobile. And bone defects after trauma or surgery, or after extraction of wisdom teeth or any other teeth. So in the same study, Horowitz said, what is better? If we don't graft and we follow the alveolar bone, as what you see is like in the upper row, you see a narrow bone after 3 to 6 months. Or if we graft with any material, synthetic, allogeneic, whatever, allograft and bovine, whatever, you still, after 6 to 12 months, you can have a nice ridge, wide ridge. And this is what today people who are doing implants or not doing implants, if they want a little bit to preserve the ridge, they use anybody is using some different materials, and there are a lot of studies what is better or what is worse. By the way, Horowitz found in the same study that he compared different materials. Are materials which are more beneficial. He didn't find anyone that preserved for longer periods of time. He used bio-os, he used the synthetic materials, he used bovine, Cerabon, all kinds of materials in this, because he looked at different studies. So he didn't have any preferred material, but all of them in some way preserve the ridge. So it's good to preserve the ridge, and you can use whatever material that you always have good confidence in that. So what are the indications for grafting today? We want to restore and maintain alveolar ridge, as I said before. In periodontal defects, it's more complicated. Bone defects after trauma or surgery, this is very important, or after you removed some implants and you have a big defects in bone, or you have almost no bone. Graft to support implants, and today grafting sinuses and augment narrow ridges. We are now living in a time that we understand much more about how to build a tissue, and we call it tissue engineering. Tissue engineering is based on 3 parts. We need a scaffold, resorbable biomaterials, usually preferred. We need stem cells or young progenitor cells, and we need also bioactive molecules like growth factors, which will activate the stem cells to grow new bone in our case. Okay. So autogenic bone and teeth is today considered the best scaffold material to grow bone. We know that cortical bone or bone, autogenic bone, is the gold standard of grafting. Not because we have a lot of cells there, because the cells that we have there die, but because the matrix, autogenic matrix, is usually preferred by, recognized by the cells of the same patient. But tissue engineering is not new. This is from the Bible, Genesis 1, and we have two creations of human beings. One is God created man in his own image. In the image of God he created him. Male and female he created them. So first of all, equality. Men and women he created them. This is in Genesis 1. And he created, not engineered. But for us, when we talk about tissue engineering, Genesis 2 is again, and here is very interesting, because here God caused a deep sleep to fall upon the man. So first of all, if he wants to do tissue engineering, yes, he needs to make anesthesia. Yes, so the Bible, which is 6,000 years ago written, okay, understood that you cannot do any surgery without anesthesia. Okay, and he was a very good anesthetist, because why he didn't touch him while he slept. Only while he slept he took one of his ribs. He did the surgery. Okay, and then it's written very well that he made into a woman, not created. This is tissue engineering. Okay, so tissue engineering was described in the Bible, and this is very interesting, that nothing is new. We reinvent always new things. This is tissue engineering today. We can take a biopsy, a small piece, for example, for cartilage, isolate few cells, proliferate the cells into many cells, into billion of cells, but we need, it's not enough that we have a lot of cells. We need a scaffold. We need a scaffold that the cells will recognize the scaffold, adhere biologically, not physically, biologically to the scaffold, and this way the scaffold and the cells that recognize will start to produce a tissue. All this is in vitro, outside the body. When we have a little bit of tissue, then we come an implant. Very, very difficult. This was started 20 years ago, and still all the scientists, and you have here in London, in Great Britain, an excellent tissue engineering scientist, Molly Stevens. She publishes a lot of papers about tissue engineering and the ways that it can be worked out, but still it is in infancy. So we understand that in our case, in dentistry, when we extract a tooth or when we do surgery, we evoke in our tissue that a lot of cells start to proliferate, grow, young cells. So that we don't need stem cells. We have them in our body, we just have to, like we say, ignite them, okay, that they start to proliferate. By surgery, we do induce them. But we need to select a good scaffold. And this is why it's important to select a scaffold. And the best scaffold, as I said before, and all the scientists and also clinicians agree that autogenous is the best scaffold, bone or dentin. Then we have allografts, then we have xenografts, and we have also synthetic polymers, TCP, HA, silicon-based, and many, many. I published, if somebody wants, we compared, for example, many of those materials in an animal study, in a rat, and we compared with biopsies from sinuses taken by Philip Roos, that what we got, that materials that are very good producing nice bone in an animal are also producing excellent bone in human beings. But this is out of the scope. So why dentin and why teeth? Because first of all, teeth is part of our jaws, is our tissue. Okay. Second, because dentin is comprised as 85% of the tooth structure. The enamel can be also used, okay, because it's hydroxyapatite only, no problem. Cementum, we have very few volume of cementum in a tooth. So also important, dentin is very alike bone, like cortical bone. It has the same HA, hydroxyapatite mineral. It has the same organic matrix, collagen, based on collagen, and non-collagenous proteins, the same growth factors, BMP, FGF, and others. Okay. So dentin, like bone, may release growth factors after it starts to demineralize, after it starts to remodel. In the same way, and also already in 1970 was shown that dentin can induce bone like bone itself by Harry Reddy and Huggins. And this is essentially showing the same, that dentin and bone comprise from the same chemistry. Okay, so how we treat today the extracted teeth? Today, millions of teeth are extracted and wasted. Experts estimated that in US only 20 million teeth are extracted each year. 20 million teeth in United States. 30% of them are extracted of loss of periodontal support, which means that most of those teeth are not root canal treated, but they are mobile, and you have to extract them, and sometimes 5, 6, 10 at once. And also we have 10% of extracted teeth are wisdom teeth, impacted teeth for orthodontic reasons also. So if we just calculate that if we can use 10% of the 30%, yes, of the 20 million, we're talking about 2 million teeth that can be replaced as bone graft. A lot of numbers. Also, extracted teeth are considered in United States, I don't know how it is here, it is a medical waste. So you cannot throw it this simple way. You have to incinerate extracted teeth containing amalgam, you have to clean and disinfect and send it to the biohazard that it is collected as biohazard. Can we give it back to the patient? Yes. After we clean it well, we can give it to the patient back. Those are the rules of American Dental Association. We say not any more medical waste. Extracted teeth can be recycled into dentin graft. Okay, some teeth are worth much more. As you see here in 2011, this tooth of the beetle molar tooth was sold for 19,000 pounds. Okay, so some teeth are very, very expensive. So don't throw them away. Make an auction. So this is papers by Kim. He showed very well from the group in Korea that teeth, yes, don't discard extracted teeth because they generate bone, which we know they generate bone, as I showed you in the first 2 slides. What they do, as I said, they have a bank, they created a bank. And in the last 3 years or 4 years, they used 38,000 teeth were this way stored, processed, and delivered back to the dentist for the same patient. Again, autogenous. But this process takes time consuming. If we compare in a study different, for example, bone allograft, coral hydroxyapatite, demineralized dry dentin, and cementum, we see that the dentin is producing much more mineralized tissue in this culture system. Also, in the cranium, when you make a graft of autologous bone and dentin, you have very nice closure of the damaged bone, while other materials don't complete the closure. Now we have done, in our study, we used here mini pigs, and we done an animal study where we extract the teeth, we prepare them as a particulate dentin, as we shall see in a few minutes, implanted, put it back immediately after extraction, and after few weeks, after 6 weeks here, we came back and we put an implant, and again after 6 weeks, we took out a piece of bone with the implant, we cut it like you see here, through the implant, and here we have the histology showing that next to the implant, we have bone, but we don't have bone only. We have a composite of dentin bone, because the new bone formed opposed directly on the dentin, okay? And what we can see also here, this is a scanning electron microscope showing the dense dentin bone next to implant. And here you can see even very nicely dentin, typical dentin, surrounded by cortical bone. We know also today in studies that were done that if you put a dense, strong material as a graft, the bone which is formed on it will be also very dense. We don't yet understand the mechanism, but this was done. I don't have the time to elaborate, but there are some very nice studies showing it. And you can see the composite here of the bone dentin that we can even not distinguish, like we only see some cement line between the surfaces. Publications. The publications about using dentin started, as I said, 1970, I believe, even before. This is by Huggins, who got the Nobel Prize, and Harry Reddy, my friend, and they showed that demilized tooth dentin and bone transform fibroblasts into bone under the skin, so they have even an inductive property. But we don't want inductive property. We want more a bioactive osteogenic property of the matrix. And here are many other publications, and more publications are done. So we believe that teeth can generate bone, and this is the procedure as you see here. We have a dentin grinder that also grinds the tooth after we clean it, and then it separates the particles between 300 microns and 1,200 microns. And as you see here, we get it in a drawer, exactly this particle, and we have at least 2 to 3 times volume of a tooth, because it's particulate. Now we have just to make it bacteria-free, and we do it with a cleanser, which I will show you in a minute. Here is a typical case. You see, who will touch those teeth? Usually they throw it out because they cannot stay in the room for a long period of time. But in 2 minutes, a dentist or his assistant can clean it with a tungsten burr, and this is after 2-3 minutes. Those teeth are now clean. And now you grind it for 3 seconds and rotate it for 20 seconds more, and the particulate will go through here into a special drawer, and this is the product which you have. And now we just have to clean it. So the Dentin Cleanser is a basic solution which has also alcohol in it, 20 to 30% alcohol, and it was shown by GE Healthcare that after 10 minutes it will make, what it does, it dissolves all the organic material. It dissolves even DNA. It dissolves also organic, it will not dissolve collagen, but it will dissolve bacteria, organic material which is soft, like plaque and so on, as you see here. We try to understand in how much time we need to have a bacteria-free product. And we found that after 10 minutes, we have a beautiful, you can see, when you start here from 0 time, yes, and all are the same magnification, by the way, dentin, you see the tubuli openings. Here are very narrow. Here, after 3 minutes, we have much more wider. But look here, all the organic materials in the tubuli are dissolved after 10 minutes, and we checked it in bacteriological studies, and it is bacteria-free. Okay. Essentially, when we put a valse teeth, we don't even wait to see if this is bacteria-free. Okay. So from those, let's say, dirty teeth, we get a bacteria-free particulate that we can immediately use it. So now, what we showed here is that dentin is an ultimate scaffold for tissue engineering of alveolar ridge, and Dr. Lari will present some cases, clinical cases.
I will show you now the cases. Actually, all of you know this and very familiar with you, I suppose, because it's a case that you, I'm sure, do it your everyday practice using any other graft. Here the difference is only that we use with extracted teeth. I will show you cases done by myself and our colleagues. This case is extracted of impacted and mesial-angulated wisdom tooth, done by Professor Kaspi Hadas from Jerusalem. As you can see here, the extraction of such tooth, we definitely will compromise the distal root of the 7th, and in our opinion, the fate of this tooth is also the next candidate for extraction. Otherwise, we do some grafting. Here you can see all the procedure after extraction. You can see the particulate dentin done by our procedure, mechanically cleaned, grounded, and chemically cleaned by our Dentin Cleanser. You can see on the right the hot plate. We are giving and we recommend to hit the ready graft, but only for storage. In this case, it's been done also in the same session. You can do it, you cannot, it doesn't matter, but for storage, we recommend absolutely to hit it for 5 minutes for 150 degrees Celsius, and just to evaporate all the liquids, to dry the dentin, and giving to the patient and keep it for years. Here you can see the site of the surgery after extraction, and the graft which reflects the shape of the impacted wisdom tooth on your right. The same case, Again, wisdom tooth with the big deep caries, unrestorable, has been extracted by me, processed by our process, by our method, and here you can see on the CT scan showing high density of grafting site after 2 months. Because, as we said, on the basic principle of the ankylosis and replacement resorption, we can get the bone-dentin interface in very short period of time. As all of you know, that a valve tooth being ankylosed, if you splint it a bit more than 2 weeks, which is enough. Here we can see the lower right, 7th and 8th. By the way, the one contraindication for using extracted teeth is root canal treated teeth. So in this case, I used the 8th. You can see extracted tooth before mechanical cleaning, after mechanical cleaning. Ready graft before, and here the sockets were filled, and I'm using pipe PRF membrane. Implantation has been done 2 months after grafting. 2 months is completely enough. You can get very solid and very resistible surgical site. By the way, you may be mistaken with the inferior alveolar canal. This is lateralization, buccal lateralization. Here in the case, our colleague used the extracted 4 lower incisors and premolars and right 7. You can see the extraction site, the lower incisors after extracting, mechanically cleaning, grinding, 10 minutes, as we said, in the cleanser solution. PRF membrane plus PRF liquid. In this case, this doctor used interdental space for implant placement in order to preserve more, despite of course, small vertical resorption, as all of you know, but he preferred such an implantation and filling and grafting of the sockets. You can see here immediately after grafting, the sockets and implant augmentation, PRF membrane covering, and the final 24 hours post-operative transitional bridge, metal-based transitional bridge. On your right, you can see 8 weeks after, and here 5 months after. You can see very solid, very homogeneous dentin bone interface. One more case, 4 lower incisors with mobility, a total tissue attachment loss, bone loss, were extracted due to periodontal disease, of course. Before cleaning, after mechanical cleaning, grafting. By the way, I want to mention here that from even the smallest incisor, lower incisor, we can get at least around 1 cc of the graft, which is in weight, you know, something about 0.5 gram. And if you get more, in this case, I get a lot of material which is left afterward, and I make the heating and the storage and give it to this patient. Because here I got something around almost 5 cc of material. You can see the implantation. 2 implants has been placed through the sockets, the same session. And using the dentin, you can see the periapical. This is another case using the also periodontal involved for lower incisors. And here, in addition, you can see periodontal abscess and radiolucency, which is also endoperiodontal lesion, which, like a cyst, involves also canine. Here, by the dentin graft, the alveolar ridge was shaping, and I got the desirable height and volume, and also the cyst was inoculated by the lateral window and placed and replaced and filled by dentin. The next case, here we can see the case of actually sinus lifting. You can see the upper right 6 with oral-anal communication, almost nothing of the bone left. You can see the orifice of the, let's say, fistula. It's not fistula, but oral-anal communication. You can see the extracted tooth and mechanically cleaned. 2 months after grafting, only 2 months, we've got 8.3 millimeter of height of the bone. And at the same period of time, 2 months after grafting, a week after, this implant has been put with the closed sinus lifting using the dentin, the same from the same tooth. And believe me, the resistance after 2 months, I don't recommend do it after 2 months, but 3 months, it's completely enough, by the same reasons that I mentioned before. From the clinical observation, we can see that dentin augmentation allows placement of implant after 2-3 months, even in the upper jaw, and as we already showed you, the dentin is directly opposed by bone, creating strong bone-dentin interface. We don't wait for remodeling. We don't wait for new bone formation. It's enough for us bone-dentin interface at all. We can go through this bone, and which with an excellent result. Professor Binderman, you want to continue?
Well, the advantages that you see here between using cortical autogenous bone and dentin teeth. Okay, so we know the morbidity of the bone autografts, okay, and the limited quantity, and usually on the other there's a contraindication. Let's first of all the bone autograft morbidity, and also its unpredictable quality of the bone autograft. Okay, sometimes we get cancellous bone a lot, but not cortical bone, unless we use some places like the chin and so on. But it is usually a surgery, a major surgery in dentistry, let's say. The dentin, the contraindication, though, the problems with dentin, that sometimes it's a limited quantity. Okay? As we said already, the volume of the particulate is 2 to 3 times more than the volume of the root. But still, if we have a big defect, we cannot use. Can we use, together with the dentin, other grafting materials? Yes, we can. I would prefer to tell you to use not animal material and not allografts, but to use synthetic materials. The synthetic materials are more soft, but the dentin, if you have together with synthetic, the synthetic, some of them are very bioactive, those who have silicium inside. Okay? So if you don't have enough dentin, you can add to it some synthetic materials. This is my suggestion. Okay. Now, of course, course, autogenous dentin is, of course, osteogenic, and what it essentially does, it is instructing, it is scaffold which is instructing the cells to start to produce bone. So it's a scaffold which is cell-instructive, which is very important. And I'm using the cell-instructive because people like Molly Stevens is also using that we need a scaffold which will instruct the cells to do a specific tissue. And this is, of course, complicated. It's complicated when you take a biomimetic material. It's complicated when you're taking synthetic material. It's not complicated when you're taking autogenous material, of course, because the cells recognize. So in summary, yes, we can repair bone defects. We can replace autogenic bone graft instead of autogenic bone graft. We can restore alveolar crest, which we showed you. And we can regenerate aesthetic and function. Because if we have an excellent bonding between new bone and dentin, then as you saw before, of course, we can, after 2 to 3 months, already have a very strong scaffold to put implants in this place. So, and as people ask me many times, so I wrote this, do we have evidence-based publication that it really works? I tried to show you that we don't need, because for autogenic tissue, you don't need essentially evidence-based publications unless we change this tissue with some materials, then we need, of course. And my answer is that medicine dentist is based on for centuries, that if it can reuse or replace any tissue in your body by your own tissues, it is the optimal way. I believe so. Okay? Well, we are not still lizards. They regenerate. We have to work very hard because we can only do tissue engineering. We don't have regeneration of this yet. We don't have regeneration of bone. Okay? So I will finish to say that on Fitz's quotes, I hear and I forget. I hope that you saw and you will remember, and more after you see the demonstration, you will do and understand. And we find from our experience that the dentist, after doing the first dentin autograft case, they usually start to doing every case that they can use natural teeth. And I would say as a dentist now, saying, you know, if we know today that we don't have to throw away tissue, and we can put it back to the patient, and people think how much it costs, it doesn't matter. Tell the patient that you can put the dentin back as a tissue that will restore his ridge, or at least maintain his ridge. I believe that he will pay more than for any other materials.
You know, we have to wear the gloves, and also because of cleanser, which is very alkaline solution. The pH of the cleanser is 14, more than calcium hydroxide. Here you can see the mechanically prepared upper molar. You can see the removal of the thick amalgam filling from here, done, by the way, by dental assistant. So after mechanical preparation, we clean it by tungsten carbide bore and not by diamond bore, because of the very simple reason: the diamond produces this heating and can damage the collagen which is inside. The carbon tungsten bore chipping, just cutting the unnecessary material in any epithelium and soft tissue remaining. So this is the machine, the base of the machine. And this is, as we said, the disposable container. Because of the chain of the places where the particles, after vibration, getting the needed size, it's very difficult to sterilize. Even to clean it mechanically is difficult also. So we decided, not only for business reason, but do it disposable. Now you will see, you will hear the cost, and you will understand. So this is the core. It's see-through. We put the disposable chamber on the base, locked it. Without locking, it doesn't work. For security reason, we put the tooth inside and also locked tightly the core. So now the cycle, recommended cycle, is 3-second grinding and 20-second sorting, which is the vibration. Once you put, this cycle will work every time. If, let's say, for this the same patient, you have more teeth than you can put inside of one container. By the way, you can put up to 5 incisors, probably 3 canines, and sometimes 2 molars, depending on the size, of course. And now we put a start. Almost done. You can see here from here that there is some particles remaining. We can repeat the grinding, which I will do. Nothing left. And by the way, I have to say that the dentin is very, very solid structure, very difficult to grind it. I used by hand bone mills by Kometa. It's very, very difficult, I must say. But here you saw it with 23 seconds and it's done. Now you can see the ready graft. We put it on into our glass container. We provide disposable droppers with our kit. The cleanser has to just to cover the material. It's like this is completely enough. After 10 minutes, we recommend 10 minutes. Actually, even after less than 10, but we recommend 10 minutes. We can using by the same dropper to take out the cleanser. It cannot be done by 100%, and you don't need to, because we have another solution we'll talk about now. And the second solution is PBS, which is phosphate buffered saline, which immediately neutralize the pH We just cover it, we don't wait, and can take it out by the same dropper, or using, if you got used to, by the gauze. Put it too much, bigger solution. You don't need just enough to cover. And here you can see the ready graft, ready for using, very comfortable in use, very plastic and moldable solution. It doesn't run away from your curds or whatever what you get used to by periosteal ureter or whatever. It's a bit complicated to give you to try by everyone by yourself, but believe me, that is as it does. And here is our hot plate. The hot plate, as I said, we are using only for storage of material. The container is hot resistant. You put it on side, of course, without the cover. Put plug for 5 minutes for, as I said, 150 degrees Celsius. Closed. On the cover, here you cannot see, but in the kits, if you want, on the hole you will see the possibility to put the name of the patient and the date, using and giving to patient, not to keep in ourselves, but for medical legal aspect of use. In the lower compartment, as we saw, lower drawer, we've got the material which is less than 200 microns, and as we think it's not useful, so just to throw it away. That's it. That's all the process.